afternoon. All right, this is going to be the slump time. They gave me the slump time, okay? So, good afternoon.
Good afternoon.
Okay, thank you. Let's start off. Anyone who's not here, raise your hand. Okay. So we're going to have some discussions this afternoon about recovery and recovery support services. Oh, I forgot to say, Janet has behaved herself pretty well this morning, but she may need some adult supervision, so if during the afternoon you'd keep your eye on her, I'd appreciate that. Okay, thank you.
I love extras.
Okay, so I have a master's degree in counseling. I'm a clinician. I've been a clinical supervisor and a program administrator, and now I've been at Brown University for about 10 years with this federal grant that provides training and technical assistance to the workforce for substance use disorder recovery. More importantly, I'm a person in long-term recovery. For me, that means I have been free from the use of alcohol and other drugs since 1986, as a result of which I have a career now and a life, and I contribute to my community. The short way I explain it to people is that when I was drinking, the bad news was no matter where I went, there I was. I could not get away from myself, no matter how much I drank or where I moved. In recovery, the good news is no matter where I go, there I am. And it makes a huge difference in my life and the life of people around me. So I'm going to, in part, talk about my own recovery experiences. If there are other folks in the room who have recovery experiences, I encourage you to please add them to the mix of the discussion today. Having a face and a voice of recovery is very important to the work that we'll be talking about today. Okay. I'd like to start by talking about language a little bit. First of all, we talk about substance abuse and substance dependence. Those are terms that have been concretized in the DSM. The DSM is now moving, in the next DSM-5, will be moving to substance use disorders as a designation. And I am suggesting that we think about using that word instead of that phrase, instead of substance abuse or other terminology. If we talk about substance use disorders, and not talk about addicts or alcoholics. Those are derogatory, negative terms. As people in the field, we want to be talking about persons who have substance use disorders, okay? And for those who are engaging, in the process of wellness, I'd even suggest this word. Can you see that? What do you think about that word? You like it? Who said I like it? Why? What?
I don't know. I just never liked the word addict. I just thought it was, I think I said, I know I said that before. I just didn't like it.
Okay. Anyone else?
Any state of recovery is good.
Any state of recovery is good. It really puts the emphasis on the wellness piece, okay, as opposed to the illness piece, okay? So who's responsible when someone is in treatment? Who is responsible for that person's recovery? Who? The recovery is responsible for the recovery's recovery, okay? We are not, no matter how smart we are or what degrees we have, or even if we're fellow travelers on the road of recovery. We are not in charge, okay? And it's one of the things that we, as a field, need to change about how we think about ourselves and how we do business with folks, okay? The recovery is in charge of her or his own movement towards wellness, okay? And gets to make choices about that. Okay? How many of us in the room would say that before I began my recovery, when I was sitting at the bar, intoxicated or on my way to intoxication, how many of us would say you admired me?
Are we talking about you or ourselves?
No, me. That you would have
That
admired.
we would have admired you sitting at the bar?
When I was sitting at the bar.
When you were sitting at the bar?
Yep.
Before you stopped using? But
Correct.
I say that I admired you.
Correct.
You could have been sitting at the bar just looking at her.
No, I'm drinking, baby. I'm drinking.
Oh, I would have seen you totally different.
It depends on whether I'm sitting beside you or not and whether you're treating or not. So I guess I have to look at it like that.
I'm way too self-centered to worry about that.
Okay. How many of you would say you admire me today because of my recovery?
Respect.
Okay, so when does that change? When in the process do we go from not admiring, not respecting, to admiring and respecting?
When a person's perception changes.
When what?
When a perception change of that person.
When that person's perceptions change, or when your
No, when
perception?
my perception changes.
Yeah, what I'm asking is, when does that happen?
When the behavior changes.
When that person makes a change. Any change?
Yes, a positive change.
A positive change. How big?
Life
It,
changes.
it, it doesn't
Life
matter.
changing?
It doesn't matter how big.
Well, that's different. Life changing and it doesn't matter are two different things.
Life change.
When you see the process of recovery taking place in
When
that
you
person,
see the process of how would you define that?
well, you're no longer at the bar. You're no longer walking down the street. You're no longer falling all over the place. I mean,
Okay.
you're beginning to be productive. You're going to work. You're doing things.
Well, those are lots of different things. So I have to have all of them,
Right.
or just
Well, no, not. I mean, just the process. You can see something different because again,
see something
you can
different?
see- right. You know,
Okay.
I have to see it. Because you
Okay.
can say whatever you want to say, but it's not until I begin to see your
The
process.
signs of wellness.
Absolutely.
Okay.
When a person say to me, I have a desire to stop, or I want to stop.
I have a desire.
I want to stop.
Okay. Expresses a willingness
Yeah.
to change. Okay.
I'm not a person with that.
Even identify, the first thing for me would be first identifying that, yes, I do have a problem. Then from there, to say, I have a desire to stop.
Okay. So, is there a consensus that I need to express a desire to change before you perceive me as someone worthy of respect?
No.
Okay. When do you perceive me as a person worthy of respect?
When I see you helping other people.
When you see me helping other people. Okay?
Always, you are a person worthy of respect, whether you're using or not, because you are still a human
Respect
being.
is
Could you stand up and yell that, please?
I said, whether you're using or not, you are a person who deserves respect always.
Always.
Right.
Right, that wasn't the question.
Ah, you're right. Okay. I'm sorry, I confused it. But no, that's important. I did say admire.
Yeah.
I was mixing the two terms when I was really thinking about respect. Okay. So that was my mistake. But I think it's important to have this conversation, the language aside, about respect. And how do we carry that through with the people we work with? What does that mean to respect someone? Non-judgmental. Non-judgmental? People what? Treat people the way you want to be treated. Can you give me an example of how you'd like to be treated? Like you're a person?
Now, I beg to differ, because I have met people who like to be abused.
Okay.
So you gotta watch that one.
Okay. So yes, right.
They think that's love.
Right. Okay.
Yes.
Right.
do. They like receiving it and they like giving it.
Okay. So, those folks aside,
Well, even though that person want to be abused, you still respect that person anyway,
Yes.
regardless of
There's
that.
clearly some issues.
You know, because we know there's an
okay, but the
underlying
issue was,
issue
give
somewhere.
them back what they, give them what they're looking for. Okay,
The issue,
So-
how do I want to be treated?
okay.
You give the person choices for their life. That way, you giving them their respect they deserve. They have to make their own choices.
One of the most important words in the work that we do, and we don't use it. Choice. Whose choice? The recovery's choice. Okay? All right. Say what?
We need to drill that to some counselors that they.
Well, let's start with ourselves in this room before we start with others.
Okay.
Okay?
I believe in choices.
And you said the recovery's choice. There's a point, even in a person's active addiction, that they can be provided with choices that they can make, especially within the harm reduction realm.
Absolutely.
You know, because
Absolutely.
there's a
And
great
part
deal
of
of
the process
choices.
of recovery is a person reclaiming healthy will to make the right decisions. Okay? I mean, certainly we don't want someone who absolutely needs medical detox to be making lots of decisions about some things. Okay? But not to dismiss the need for choice. Okay? Not to dismiss the need for choice and help that grow, that sense of self-management, because that's where it comes from. Okay? So this is what we'll be talking about as we go along. Okay, I just want to thank Faces and Voices of Recovery. How many of you know about Faces and Voices of Recovery? Just a couple. Okay. Faces and Voices of Recovery is a national advocacy organization that works to organize and mobilize the recovery community. By the recovery community, we mean persons who are in recovery, persons who are striving to be in recovery, their families, friends, and allies. Okay? And our key thinking on this is that by our silence, we let other people define us. If we, as people in recovery, as the recovery community, do not speak up and do not speak out, someone else gets to set the agenda.
Yes.
Okay? Now, I know that there are traditions for some people in recovery and people interpret those traditions as meaning you have to be silent, you have to be anonymous. That's a misinterpretation. Okay? When we are silent, we let the prejudices and fears and lack of knowledge of other people set the agenda. That has to change.
Yes.
That has to change.
And just to piggyback on what you're saying, I have always been one of those professionals, because I'm in recovery as well. I've been in recovery since '84. And I think personally, as professionals, if we were to speak out as professionals, like you said, and say, because I'm not ashamed of it either, you know, how I was and how I am today, that as professionals, if we can speak out about our recovery, to know that we are recoveries too.
Yes.
And you can build a fantastic, better life.
Yes.
You know,
Yes.
we don't have to stay in the mindset of being sick. Like you said, we do get well.
Right. And Jeff mentioned that this morning, that we want to be creating a health care system. Okay, not a sick care system, but a health care system. So we want to be focusing on wellness. And notice, I did not use the terminology alcoholic to describe myself. I said I'm a person in long-term recovery, putting the emphasis on the wellness, not the problem. Okay? And right from the get-go, for folks who come into treatment, we need to help them see that. Okay? That they have the capacity and ability to speak for themselves. Okay? And that that's part of recovery. Okay, so right now, a couple of slides on how we manage tend to manage things right now, that a professional, that's us, directs and dominates the assessment, treatment planning, and the decision-making process. Would you agree? No?
Yeah.
How many say yes? That that's the way we generally do it? Okay. Yes? Okay.
That's generally the way we do it.
Okay. Is there generally a professional in charge of the process?
Yeah.
How many say yes?
Yes, a person
Yes.
in charge of the process.
Does that person do most of the decision-making now about the movement towards wellness? No? Who says no? Because I want to hear those examples. Okay.
Again, we go back to choice.
Yes, but I'm not talking about the ideal, I'm talking about the actualization in the moment, in the way the system works now.
And so, in certain treatment facilities and therapeutic communities, you come into that facility, they have a set of rules, regulations, and guidelines that you must follow, and if you don't do it the way they say, you're getting put out.
Okay, one example. Over here?
I think at first, when an individual first come into treatment, the first initial treatment plan is mostly kind of dominated by that clinician a little bit. I mean, of course, they say, some programs have like a 30-day treatment plan, where the 30-day treatment plan is basically the same for most of the people coming in there. And because a lot of people, when they do come in, you start asking them questions, they say, I don't know. A lot of them are not, they don't know.
That's true. That's true. There was a hand back here.
I think during the course of the assessment, I think you have to give the client options and give him a choice or her a choice. And depending upon the clinician is how that's done.
Right.
Yeah.
Yeah,
Okay. We're going to get more into this as we go along. But just to do the setup here. So we have services. This is treatment. It's an acute care approach right now. It's the current problem that the person has presented with, yes? Okay. This episode. Okay. So we have a short period of time that treatment occurs. We'll talk more about that. The services address the current acute problem. And for those who have insurance, or even public dollars that are in some cases limited, there's a time limit that this has to be accomplished in. Okay? And I think the idea in many places is given, well, when you walk out the door, you're fixed. Or you should be. If you're not, it's your fault. Okay? Let's talk about who it is that we're actually treating. So this is a slide from Mark Willenbring, who was at NIAAA, the National Institute on Alcohol Abuse and Alcoholism. And he has a very nice article that this is included in. He says, starting on the left, that 71% of the adult population, people 18 or over, in the US do not use or use with no problem or risk, use alcohol with, either don't use alcohol or use it with low or no risk. Okay? 71%. 21% drink with some level of risk. They have a parent who has a substance use disorder, okay? For instance. 5% would meet the criteria for what we now call substance abuse, the lesser of the two categories. Harmful drinking, he calls it. 4% would meet the criteria for dependence, with 1/4 of them being chronically dependent. Okay? What he says, and I think this is true, and I'll ask you whether you think so too, that these are the folks that we see and treat, and therefore we have developed a thinking and a profile about who needs treatment from these folks and put it on to everybody. What do you think about that?
I think that, some people can drink sociably, or they can drink, and then you just have other people who may have a predisposition, and they fall in, that category. It's not just the alcohol. It could be some type of drug, it could be food, it could be if there's this addictive personality. It could be.
Yes.
You know, it depends on the individual as to whether he sees it or she sees it as a problem, not in fact, you know, what it states in a book. I mean, that's the way I look at it.
Say some more about that, please. How does that differentiate?
Because, you know, I had a person one time drink 6 beers, and he couldn't stop drinking 6 beers every night. It was a problem to him, and he had a job for a certain organization in the country that he couldn't get away with it.
Okay, so one important criteria is whether or not the recovery sees it as a problem and how big a problem. Okay? But I think what happens in most cases is that we impose our profile on people. When you look back at the history of alcoholism treatment, there's a guy named Jelinek from the 50s and 60s, and he wrote about alcoholism and he called it a progressive disorder, a progressive disease. People took that to mean inevitably progressive, so that, you know, once a cucumber becomes a pickle, you can't become a cucumber again. Okay? People assume that once you start with risky drinking, you're going to end up here anyway. So even though you're back there, we might as well do to you and for you what we would have done over here, because you'll end up here anyway.
But that's not necessarily true.
That what isn't true? That that's how we do it, or that that's workable?
You're saying, according to this research here,
Yes?
that they're saying if they start there at 21%, they're gonna end up at 1%? Is that
Well,
what
I
this
think there's
research?
a thinking for many people that the 21% will inevitably end up down there with a chronic dependency if they don't become abstinent and take care of things right now.
Okay, well, and that's why I beg to differ, because when you talk about research,
Yeah?
see, you talk about research, again, you can look at manipulating numbers, because I disagree with that as a researcher myself. Now, and I don't think that.
You disagree with what part?
You're saying that that 21% is gonna eventually get down into.
No, I'm not saying that.
Research.
No. What I'm saying is that I think the concept in the community of providers is that.
Yes, but not
Okay.
you per se.
No,
Not you per se.
on the contrary, okay? So one second. As an example, it would be like saying to someone who is pre-diabetic, you better start taking insulin now, okay? When that's not what's called for.
Right.
I thought you were quoting Jelinek.
What?
I thought you were quoting Jelinek.
Jelinek called it a progressive disorder.
Yeah, and that's what I thought you were saying was his theory, that the 21% would inevitably.
No. What I said was, people interpreted Jelinek
Oh, okay.
to mean that it was inevitably
Okay.
progressive, as
Okay.
opposed to that no one starts out alcoholism as a drunk. It doesn't happen that way. It progresses across. That's what he meant. People took his research to mean
Yes, I agree.
you'll inevitably end up there if you keep doing what you're doing now. Yes?
So what you're saying is that in society, there are groups of people who are saying to the 21% that you should be going to 90 meetings in 90 days. You should get a sponsor and a home group.
If they show up at the door of treatment, that's exactly what they hear.
Right, but it's for that 21%, that's probably not the thing that they need to be doing at that point.
Oh, I would say it's greater than probably. Yeah, that's exactly right. Okay? We're imposing this extreme end profile on everyone.
I think the reality is that by the time an alcoholic seeks treatment, they're already at the chronic stage. So, like there may be some, for whatever reasons, alcoholics and or any other person that abuses any substance that will seek treatment at the early stages before they have lost everything.
Why do you think that is so? She's saying that most of the people who knock on the door of treatment have a significant level of disorder right now. Why do you think that
The
is?
exception is if they are under parole and probation,
Right,
the judicial
mandated-
system, or
mandated
if they're
treatment.
mandated through anything other than that.
Why do you
because-
think that is?
Because the disease is chronic and progressive, by the time, I think, that a lot of people going to treatment, they're already at that chronic stage. Why do I think that is?
Yeah.
That's $1 million question. For whatever reasons, people decide not to seek treatment until they get to that point. It's a choice.
So this is an important point.
It goes back to choice again.
Okay. That many people show up at the door of treatment, people who are at this right end of the continuum of severity. Yes.
They won't be accepted into treatment unless they're dependent. I mean, the insurance company's not gonna pay for it
That's
unless
right.
they
That's one
got,
thing.
unless they got a whole lot of money.
Okay. And Jeff talked about that this morning, about how you have to be sick or very sick in order to get services. That's one good point. Yes.
Dependence,
What?
where they differentiate between the abuse and dependence person.
Yes.
Yes.
To answer your question, why? Maybe because the society is treating them like they're under the 1%. They may go to work smelling like alcohol, even
Yes.
though they're doing their job. Then they will be referred to seek treatment, or the judicial society will refer them to seek treatment. Why they are not sick with that?
Okay, so what I think I hear you say is people don't go into treatment because it doesn't fit them. Is that essentially what you're saying? That
They don't choose to go to treatment if they are under the 21%. But
They're not in the
sometimes-
1%.
Sometimes they are forced or mandated to seek treatment.
Sometimes they are.
Yes.
Yes.
As if they are
Yeah.
under the 1%. So that's
Yes.
In most cases, like she was saying, they have had a big loss or something has happened in their life. That's why when a lot of people go to treatment, the first thing they say, what brought you here to us? And in most cases, some people, a lot of them may say, I've lost, my family has no faith in me anymore, I lost my
Okay.
job, and things like that.
So that's the kicker, you're saying, why people end up seeking treatment.
I believe, not all, but in majority cases, yes, I do believe that.
I think that that's an element of it, but I also think that some of these people don't seek help because the kind of help that's available is not the right size for them. Okay, what we have is extra large. They're a small.
So you're saying the treatment is not tailored for that person, it's tailored for
Yes,
that
exactly what I'm saying.
Right,
It's
that
not safe.
21%, it's a model. It's a model out that deals with the brief counseling. And that
Yes.
21% needs that brief counseling model to bring in that intervention early on to change that kind of behavior and that kind of use.
So the point of this whole conversation,
It's not a one-step model for everybody.
yes, exactly. The whole point of this conversation is for us to be able to differentiate severity of problem.
Yes.
Okay? So some people have the ability to make a lot more healthy of a choice when they come in the door than others do. Okay? This is either there from the beginning or it hasn't been lost or whatever, and we'll talk about that more. Okay? But not everyone comes in incapable of making healthy choices. Okay? Not everyone comes in incapable of making healthy choices. Okay? So we cannot assume that as part of the profile. So, okay. Some people need some treatment some of the time in order to establish sustained recovery. Not everyone needs treatment. Do you believe that? Yes? How many say yes?
Some kind of therapy they may need. When you say this different treatment, when you say, okay, when you say some treatment or therapy or outpatient, see, counseling can be intensive, IOP, OP. So when we say
I'm not
treatment.
okay, I'm talking about something that is done by a professional
Yeah.
in a time-limited manner that involves therapeutic or medication interaction with folks.
Okay.
Those three things.
Okay.
Is it done by a professional? Is it paid? And does it involve a specific therapy of some kind?
Right.
All right?
And
I'm not
everybody-
differentiating modalities of treatment,
Everybody
okay?
doesn't need the same level.
Right. So in fact, NIAAA says, you ready for this? 70% of people who meet the criteria for substance dependence resolve those problems by themselves within, and this does sound weird, but within 20 years, and half of those are able to use alcohol non-problematically. The solution for them is not abstinence. Okay?
Question, are we talking about just alcohol here? 'Cause we're not talking about other drugs, I know.
This research is about alcohol.
Okay.
Okay? Okay? Abstinence is not the only resolution for alcohol problems. Why are you shaking your head?
I disagree with that, what you just
I do
quoted
too.
from, what you say, and I what?
NIAAA, the National Institute on Alcohol, they're the chief research agency on alcohol.
They might be drunk on that one.
Well, I think it's important for us as clinicians, you said you were a researcher, I could give you some citations. Read the research.
I read it, but that doesn't mean I agree with it. I read
Well, it is data.
Yeah, it may be that, but I've done some research too, and I beg to differ with what you're saying about NIAAA.
Okay, so all I can do is give you the facts as I know them, okay? That there are people, a large proportion of people in our society who have alcohol use problems, who resolve those problems by themselves, and it doesn't always mean abstinence.
And so what are some of those problems and what are some of the
What's the
solutions
resolution?
to,
Yeah.
what are some of the solutions to those problems?
To
How do
these
they-
problems?
No, you said that some people
Please.
don't have to have, they don't have to be abstinent from
Right.
alcohol and they resolve those problems. So what are some of those problems and what are some of the
Oh,
solutions?
it might have been
to
marital
those problems?
conflict.
Oh,
It
so-
might have been a work problem.
Okay.
And also, you can also consider the subject they
You
were
get
using for that
divorced and
research
you
as
can-
well. I'm sorry. I was just saying, you also got to consider the subject that they were using for that research. I mean, because
The subject matter.
you know, the subject, the population they was, you know, that they was actually using for
I'm
that
pretty sure this
research.
came from the National Household Survey, which is over 20,000 people.
Well, I don't know, I mean,
But do you know how many people?
Yeah,
the
one house.
reason why I'm saying, I mean, because there's some folks that use alcohol that probably was not even included in that research. A whole bunch of, there's a bunch of folks who use alcohol was not included in that research.
That who are alcoholics?
I mean, like, for instance, my uncle's alcohol, he wasn't included in that research. I'm just saying, I'm just curious to know what was like the population, and was this a working group? You understand what I'm saying? Was this a working group? Was this unemployed population? I'm sorry?
What were the demographics of
Right.
Yeah. What type of study? What type of study?
Can we hold on one sec, please? I'm glad you're all invested in this conversation, but I do want to move us forward. I'm fairly certain that NIAAA, which is part of the National Institute of Health, set up a standard research protocol, okay, that included a wide range of demographics, okay? It does seem unbelievable because we have a picture of what we think it looks like. It doesn't look that way when you look at the data. Okay? The picture we have in our minds that we've had for a long time, that we were taught, is not the correct picture. It's got to change, and there's data that will support that.
I work in a hospital.
Okay, please.
I work in a hospital, and they believe that, according to their medical model, alcohol does no good for the body. It can wreak havoc on internal organs,
Well,
including
that's
the liver.
true.
Pregnant women who drink are at risk of having a baby
Yeah.
with fetal alcohol syndrome.
Yeah.
And there's no benefit to alcohol consumption. There's no.
Okay, but
there's no-
we're not talking about the benefit of it. We're
Right,
talking
so
about
why
whether or
drink-
not the
why
use
drink
of it
at all?
creates
Right.
well, because people like it. And some people can use it without malfunctioning, if you will. Okay, hold on, please.
Go ahead.
Aren't there still groups like AA, but not AA, I forgot what they're called?
Moderation management?
Yes, that teach people how to drink
Yeah.
controllably. Aren't they still
Yes.
out there? Okay.
Yeah,
Yes.
yeah, they still there, yeah.
So
Yes.
that fits the model, what you're talking about with the
Yes.
research. Okay.
Yes.
And I also think you're addressing a group that has a bias because what we've been working with for the past 20, 30 years.
Exactly.
I mean, I think,
And I mean, of Alcoholics Anonymous, I come through that tradition of abstinence, okay?
Well, some people go to
But-
church and get sober. Some people don't.
Absolutely.
But see, we're talking about different groups here. It's different groups, different models. And there are some groups that, like she said, go to moderation drinking. There's some groups that go to church and not drink. And then it's, but you just happen to be speaking to one of the groups that come from the old school. That's all.
Yes,
But that doesn't mean we don't understand that from the other people. But we gotta be specific about the research and what groups they're talking about.
And I would suspect, I mean, like a lot of them might have been came from like Father Martin Ashley. I mean, some of those folks might have came out of that population, the
Please,
target
folks,
population.
please. Go
Yeah,
ahead.
the target population, what I was just in question about, what was the target? Yeah, the
So-
target population.
Part of the problem is that we have in our minds that this picture, these folks, as the model for everyone. It's not true. Okay? It's not true, and we've got to change how we think about the person who's walking in our door. Okay? Okay. So, treatment in the recovery spectrum, because treatment is a part of recovery for some people some of the time, yes?
Yeah.
Okay. It provides stabilization of one kind or another, physical, emotional, social. Okay? Stabilizing. It has to meet the outcomes, or it strives to meet the outcomes that are established by a number of folks, either the recovery, the payer, regulators, etc. And its purpose is to initiate and enhance the knowledge, skills, and attitudes, that is, the competencies a person needs to support and sustain recovery. Okay? For folks who need treatment, it is an initial step into lifelong recovery. It is not recovery in and of itself. Okay? Are we agreed on that? Okay.
That's like, your topic, actually said that that's under the acute care model.
Yes.
That's what that's under.
Yes.
Okay.
That
so-
profile is under the acute
Right,
care.
that's what that's under,
Yeah.
so
Yes.
we need to
Yeah.
keep, so for me, I need to keep in mind that that's what you're talking about.
Yes.
That part.
And only that, because as we look, and if we're gonna treat addiction, as a chronic illness,
Yes.
okay,
That's why.
this doesn't apply.
Well, this does.
Well, I mean, if we, then,
Yeah, the other one. The
yeah,
previous slide.
because we're looking at, if we're only looking at it itself as an acute model.
He said severity of problem. Yeah,
Well-
but that's what I was saying, different models.
Okay.
Exactly.
The acute model says, A, we're only going to pay attention to what's happening right now. Our response is going to be limited by who's paying for it, whether it's the state or an insurer, okay? Both in length of time and what services you get, okay? And when that's finished, we're done with you.
Well, no, we're
It's
done.
not connected to life.
The implication is you're
You've got
cured.
yourself.
You're fixed, you're
Right.
cured, absolutely.
So.
Yes, yes, and if you weren't, it's your fault. Okay? Now, some folks only need a brief intervention. Okay? Some folks don't need, and the intervention might not be with one of us. Okay? It might be with their faith community, it might be with their boss, it might be almost anyone. Okay? But it doesn't have to be a paid professional. Okay? There are So as this goes up, we have the intensity of treatment increases as we go along here. Okay? Yes? Yes. Okay. Okay. So these are federal data that looks at the average length of stay in a treatment facility. It's national data. For outpatient treatment, it's 92 days. Now, there are other modalities, but let's use this as an example. 92 days. 3 months, 13 weeks. If you go to outpatient counseling once a week, okay, that's 13 visits, provided you go to all of them. Okay, take away one of those for an assessment, you've got 9 hours. Well, they're not really hours, because they're really 45-minute sessions. Oh, it's not playing. Okay. It's supposed to play the song from the dance thing on Broadway. I'm having a singing moment. Anyway, 9 hours. So the question we need to ask ourselves is, this is the length of our contact with someone. What needs to be done? What can be done? If this is all the time we have, and let's go back and say, you know, while these increase to 24 days or 59 days, let's assume that the severity of problem is increasing as you're going to a more intense level of care. Okay? So these are folks who needed an outpatient level of care. Okay? We had 9 hours on average to interact with that person. Not a lot of time, is it? Okay, when you look at it that way. So thinking about what can be done, what needs to be done, are really, really important. Okay? So the basic change, I think, is to shift our attitude from the short term, the acute model, we're going to fix you, to long-term, making the person capable of carrying on long-term recovery management. Okay, because the recovery is going to live that recovery in the community, presumably for the rest of her or his life. Okay? Is recovery? What do we mean by it when we say recovery? Okay? Which is an important question, because I think every one of us would define it slightly differently in this room. Okay? So they said it was characterized by 3 things: sobriety, personal health, and citizenship. Now, and they spoke about each of these in some detail. I think we can enlarge sobriety to talk about either a reduction or elimination of the symptoms, if we believe in a harm reduction model. Okay? Personal health, how I take care of myself, physically, emotionally, how I see myself, self-actualization, self-esteem, all of those kinds of things. Whether I go on to get an education, that sort of thing. Citizenship, I really balked at this word when I first saw it. I didn't like it at all. And I've come to really, really embrace it, because I think what it says is we as people in recovery can set ourselves up differently. So we have a recovery community center just outside of Providence, Rhode Island. I'll talk more about it later. And this is a center, it's like a senior center for those of us in recovery. Okay? In the last year, they have had 2 blood drives there. And the blood bank said they were the most populous, in other words, they had the most givers anywhere. Okay? People in recovery giving blood. Seeing ourselves as capable of, as being citizens, so we contribute to the community just like everybody else. For us to see ourselves differently, and for others to see us differently. To re-engage in the community. Okay, it's part of the fullness of recovery. Yes?
I want to
Institute.
Yep.
How realistic is that to share in a training or the statistics? When we're talking about the Betty Ford Institute, it's clear it's a different.
No, it's not the Betty Ford Center.
Okay, but the Betty Ford Institute. Okay, but when we talk about, let's say,
they hosted it.
okay, well, let's say
It was
it's
a
something.
wide range of people.
Okay, let's say something like the Mountain Manor. You know, or the BSAS people. You know, or culturally, they, you know, those institutes like that. When we're talking about culturally, you got to look at sobriety, personal health. So even when it comes to eating well, it is very expensive just to eat well when you talk about personal health. So what, are they looking at that part when they talk about personal health, how to sustain that? When we're talking about cultural needs, sobriety, okay? And so how can we say personal health, and is that included in all this kind of research? When we're talking about personal health, what are the variables that they are including in this?
Well, what they're saying is there are 3 dimensions that constitute what we think of as recovery. 3 important elements. Whether or not the person reduces or eliminates the symptoms or the actual problem, the drinking or the using. Secondly, do I see myself differently? Can I take care of myself differently than I did before? That's my personal health. And thirdly, do I reconnect with my family and the community in some ways? Okay? They put out some, like the World Health Organization scale on wellness as a possibility for measuring personal health. It came out of the United Nations. Okay? It's a tool. You could use almost any tool you wanted to measure that. What they're saying is paying attention to and resolving some personal health issues is important in the lifelong process of recovery. Does that help?
Well, I understand what you're saying, but I'm looking at that population. What do we do for them, or how can we help them? What can we measure for those who are not able to, let's say, buy the type of food that's needed?
That's exactly the question we need to be asking, okay? But not here.
Yes, I know, but I'm just saying, you know, for other people to know too, since you're teaching this, the question is, what can we put out there to help?
How do you make this real?
Yeah, how do you make it real?
How do you make it real, okay? So this conversation just started about 5 years ago, okay? And they put it out in order for us to begin and have these dialogues, okay? And they're not saying they came to a resolution. They're saying, hey, here are some elements we think are important to discuss, to work out, to define, okay? What kinds of instruments would we use? Those sorts of things, okay? This is Bill White's, if you don't know about him, he's kind of the guru of the Recovery Management Initiative. He says that recovery is the ongoing experience of actively managing my continued vulnerabilities to my substance use problems. Actively managing my continued vulnerabilities. What do you think about that? What?
Is such problems any problem, or?
Okay.
No, he's talking about substance use disorders.
Okay, to
Okay,
manage.
hold on, please.
Isn't that kind of defy like a 12-step model where they have to surrender to?
Well, that's asking about the 12-step model. That is one pathway. Not the only one, but it is one pathway, yes. Yeah. Who does that give responsibility to for recovery? To the recovery. Okay? It says that I need to actively manage whatever vulnerability I have to my alcoholism. Now, let's...
Yeah, just so I'm on the same page, when you talk about recovery, you're talking about the individuals that's for the drinking population, or you talking about folks using multiple substances?
Multiple substances. My problem happened to be alcohol.
But the study, what the study did was on alcohol, right?
The one previously from NIAAA was alcohol. Yes, yes.
I'm just making sure, because I'm making sure I understand which you're going back and forth.
Well, I don't think it makes a huge difference.
Okay.
I really don't.
It does, it does.
What?
Because if you talk about, I'm just saying it does, because if you talk about a target population who has a host of resources, who has, I mean, is employed, I'm just saying.
We're going to talk about that
Okay.
right now. All right. So, if we talk about this issue of risk and vulnerabilities, what does someone showing up at the treatment door have in terms of problems? Okay? We want to assess that. Okay? But what is it that would counterbalance that? What, if we said, okay, you've got all these vulnerabilities and risks, what is it? Their strengths. Okay? What we might call resiliency, or what Bill White terms recovery capital. That's recovery capital, are those assets, internal and external, that I have available to me and that I use in order to begin and sustain my recovery. Okay? Everybody comes in with different risks and vulnerabilities. Everyone comes in with different levels of resiliency and recovery capital. The problem is we don't ask about these. We're very good at defining the pathology, what's wrong with someone coming in the door. We don't assess the person's strength. Now, wouldn't you think that if we only had 9 hours for someone who had a level of problem for which outpatient treatment was appropriate, that we would want to find out what resources they're bringing to the resolution of this right from the get-go? Yeah. Wouldn't you want to know? Yeah. We don't. We don't ask.
But is it when they do assessments, that has always been an assessment that I've seen.
Oh, please.
Please, no, I'm telling you, since 86.
Because, excuse me. I've been a program administrator in lots of programs. We have the questions on there. What are your strengths and what are your weaknesses? It's bullshit. And that's a clinical term. Okay. We may ask those questions, we don't use that information.
I believe it's an individual
Yes.
as far as the clinicians, because
Yes.
in my training, I was taught that I had to help build some strengths
Yes.
in order for the client to feel good about themselves to where they would take the step.
I will tell you, because I have an opportunity to talk across.
I'm not being disrespectful.
No, I hear you. I have a chance to travel across the country and do these kinds of training. There are individuals everywhere who do that. As a system, we do not do this. As a system. Okay? You may do it. Hurrah, thank you.
I did it because of my own recovery, looking at my own experience.
Sure. Yep.
Yeah, you're as a system, we don't do it because we are in a rush to finish, to make sure we are updating the paperwork instead
Yes.
of working
Oh,
with
yes.
the individual.
I know
so
the-
it's like in this profession, we are in a race to complete the paperwork for this organization, for state, for federal, for whoever that's giving money to the program, that we forget about who we are there for.
Exactly. What pushes us is not the wellness, but the paperwork.
Exactly. Right.
Okay?
Right.
So clearly, yes, that's a problem.
But part of the system, I do believe that because of the system, now in the addiction field, people have to be certified and licensed now to come into the field because of a whole lot of stuff not happening. So there was a lot of contributions to make this change come about.
Well, okay. It is true that most of us are licensed and certified now and even master's level. It doesn't mean that we know what to do or how to do it correctly. It doesn't mean that. There's a difference between what are laid out as competencies and what people actually do.
There's a discrepancy between what we see as asking for strengths and what you do. And I think it would help, if you want to take the time, could you do a quick role play of like the way you would get a strength or assess recovery capital from somebody?
We're going to go into what's recovery capital. Okay, so as we go along, I hope you'll get your answer, but ask me again if we haven't, okay? I'll be glad to do that. So what we think of as recovery needs to shift from what is it we take out of someone's life, the drug use, the alcohol, to what is it that we're adding, the person is adding to her or his life, okay? I talked about those, okay. Talked about those. Okay, so let's talk about this recovery piece. There are 4 pieces of this that I want to talk about with you. Recovery management, enhancing that choice piece, what is this recovery capital stuff, and then peer support. Okay, so recovery management is this philosophy of how we organize and think about the delivery of recovery services. Okay? It means, can we figure out ways to get to people before the problem becomes too big? Okay, before they need treatment or a significant intervention. Okay? How can we improve the way we initiate and stabilize folks? This talks about a variety of pathways. There are, excuse me, one of the key elements of the discussion that we need to continue to have is about the many pathways to recovery. Okay? Most folks think that you either go to AA or NA, and that's it. That's the pathway. There are many pathways to recovery. So my dad had alcoholism. I did describe him as being sober, but not as being in recovery. And someone challenged me on that, and I said, well, he didn't go to AA, he didn't go to counseling, he didn't do all the work that I did for my recovery, okay? And the person challenged me and said, okay, but that's what his recovery looked like. Just because it's not yours doesn't mean it's not recovery, okay? There are many ways to get to wellness, and we need to be honoring these and understanding these. How many of you know about SMART recovery? Wow. SMART recovery is a mutual aid group that's based on Albert Ellis's rational emotive therapy. It's not spiritually based. Okay? Why aren't we talking with people about that as an option? How many of you know about Women for Sobriety? Wow. Okay? Another big option. Okay? We can't limit ourselves. We've been dominated, and I say this as a loving member, but we've been dominated by the AA is the only way, and it's NA and that's what CA, and that's what that 12-step model is the only way to go. It is not.
Right, but you know they have the 12-step model for those who don't believe. The agnostic and the yeah. So it's not just when you said about not different pathways.
Yeah.
They are a lot non-believers spiritually, and they have the 12-step for those who are non-believers.
Sure. So that's a
So it's, yeah.
But there are lots of them. Okay? And AA, contrary to what you hear, doesn't fit for everybody. Okay? So recovery management is about creating a sustained health management partnership. Who are the two partners?
You and the recovery.
Yes, you and the recovery. It's about focusing on long-term recovery maintenance and quality of life. So the way we think about how we provide these services, that it's a wider array of the kinds of services than we might have thought about before, including housing, vocational support, daycare, transportation, all sorts of supports. Over a greater length of time, so instead of doing it for 30 days, we might do it for 6 months or more. At a lower intensity, so we don't do as much. We don't require as much, and therefore the cost is lower. This is my new slide. Is there anyone here who doesn't know who that is? Okay, good.
I don't think there's anybody in here that young.
Okay, good, okay. Popeye, what was he about? Strength. Strength, olive oil. He was about strength. Recovery management is about strength, not weakness. Okay? And the way we build that strength, the spinach, is recovery capital. And we're going to talk more about that. Okay? But we want to be focusing on people's strengths. We want to help them see the strengths that they have that they know about, the strengths that they have that they don't know about. How many of our recoveries come in and aren't aware of the strengths that they have? Okay? Can't articulate them. And then we want to be thinking about strengths that the person doesn't have, but that would be helpful or essential to the recovery process. Get out of your way. What do you think? Does that resonate? Do we operate that way? Do we? Do we really operate by trying to rehabilitate the power of choice? I think the system as a whole isn't structured to do that. Okay? So what we're left with is someone who may have been successful at obeying all the rules and having negative urine screens and gone to all the meetings that you said sign off for, may have met all of those outcomes. Does that mean that person has what it takes to sustain recovery from that day forward?
No.
No. Okay? And relying just on those actions, those behaviors, as a way of measuring the potential for long-term success is disingenuous at best. Okay? Okay. And we're not the only ones. I think that the recoverees, the patients, the clients that we have this set of expectations. They're all ready to answer that when they come in for the assessment. They're ready to answer those questions about what that is wrong. Yes? Yeah. They know all that stuff. In some cases, it's well rehearsed because you're not the first person they've had to answer those questions for. Okay?
Not miracle workers. We're not miracle workers.
We're not miracle workers. Okay? So recoveries will require education to uncover whatever are their aspirations, strengths, talents, and abilities. Okay? People in recovery or are attempting to achieve recovery are often poor historians of their own accomplishments and achievements. Would you say that that's accurate?
Yes.
Yes. I think it is. So there may be a lot more strengths and achievement, if scratch the surface a little, than what there appears to be when the person first comes in and sits down with us. Yes?
I just want to say, because a lot of the times, as a person progresses in the recovery process, then if it's not revealed at the initial assessment, which if you do a thorough assessment, they will tell you that, but not everybody is so forthright with information.
Yeah.
As time goes on, though, you will find that a lot of them have degrees and have education and have skills, have trades, and have talents.
Mm-hmm.
They are so quick to focus on they will quickly remember all the wrong, negative things.
They're getting fired.
Right, but I believe that's associated with, the behaviors are associated with our disease and the drinking problem.
With what?
With the disease.
Yeah.
It's associated with the addiction and the drinking and whatever drugs they did. And so that's how it's easy to relate the negativity to what we've done because of what we've done. But in absence of all of that, then we can begin to focus on what our strengths are. But as long as we're under that cloud, we know we have them, but it's really not that, we really don't speak on it that much, as a recovering addict myself.
Okay,
Right.
there's another one in there.
So I understand
Okay,
that,
great.
I understand.
So we're very good at, first of all, asking, please tell me all of those things, those deficits.
Right.
Those are the first questions we ask, the deficit questions. Okay, yes? Someone, a hand back there?
I think that when people enter into treatment, they're in pain.
Yes?
And when you're in pain, that's the first thing that comes to your mind to talk about. I mean, if I have a
So
broken-
what, okay,
if I
so
have a
if that's the
broken-
first thing that I'm sort of engineered to talk about,
I would
what's,
say engineer,
okay.
I'm in pain.
I'm in pain, that I'm
That
driven
is-
to talk about?
That is the thing that's most on my mind.
Okay.
If I have a broken finger and go to the doctor and they're asking me about other things, I'm like, dude, my feet are fine, but my finger's broken. That's why I came. It hurts.
Yeah.
Give me something. And they'll probably give me a bottle of OxyContin, but
So when we're in pain, we focus on the pain, okay? What is the job of the helper?
That second thing, I didn't get to finish. I like that. You require education to uncover their aspirations and possibilities. Because like the young lady said up here, when they first come in, they're talking about the pain, but assessment doesn't happen once. Assessment is a process. So we're going to be slowly uncovering, talking about, giving them the opportunity to release some of that pain so that we can focus a little bit better on. So tell me some of the strengths. Tell me some of the good things. You had a week clean. That's amazing. Now, most people would say that a week clean was ridiculous. That's not even, we don't even want to talk about that. That's a joke. But somehow they managed to stay clean without something for an entire week. How did you do that? Let's talk about that. What was successful about that week? And to be able to get those strengths and talents and abilities out of that. But that takes time. 9 hours.
I was just going to say, you need to caution everyone, strengths are not about recovery. Strengths are about life. And so it's not talking about necessarily that you stay clean that week, but you got here alive. What have you been doing your whole life to stay alive? And there are strengths not related just to the substance that they're using. And I think that's where people get, as a profession, we get too narrowly focused on just the substance that you use today and not the life that you've lived to get here. And that's where the strengths are. And that's what's going to get people out of whatever the struggle is.
I think that's true. That's true. So we also require education about what we're going to look at as strengths, talents, abilities. Okay? Widening our own scope. So again, there are many pathways to recovery, and the person gets to make choices to select the pathway and style of recovery that represents his or her personal or aspirational review. So if I go to an opiate treatment program, any of you work in opiate treatment? Okay. So if I go to an opiate treatment program and I say, yep, absolutely, the opiates are a problem, but I smoke marijuana and I'm going to keep smoking marijuana. How do you react?
Tell me a little bit about your marijuana use.
I smoke several times a week.
What are some of the good things about it?
Pardon?
What are some of the good things about your marijuana use?
Oh, I love just getting away for a while.
Okay. What else?
That's the big thing. It's sort of a mini vacation.
Just like getting away.
Yeah.
It's a good thing to get away.
Yes, it is.
Do you see, are there any things that you don't like so much about it?
No, not really.
Okay. So what can we do for you?
I want to get off the oxys.
What are some of the good things about the oxys?
There's not much left that's good anymore about that.
Okay. So there's really nothing left. Were there things previously that were good?
Oh, sure. The high was really nice, and then the was really nice.
So you like the high, what was the what's this?
The sort of nodding off thing.
Nodding off?
Vacation. Yeah, more of a vacation.
Okay. So you like to be able to take a little bit of a vacation.
Hmm.
So any other good things about it you can think of?
That's the primary one.
Okay. So are there things, you said there were things that you don't like about it. What are some of the things that you're not really fond of about it?
Yeah, well, it's costing me a lot of money, and it's created some work problems and some relationship problems, so.
So I reframe all that and say, so what are you interested in doing about your opioid problem?
I want to stop that.
Okay. How would you, any plans on how to do that?
Well, yeah, you guys give medicine, don't you?
We could, if you want to talk about that.
Yeah.
Sure. Are there medicines that you're interested in, you know things about? Like what?
Well, don't you do methadone here?
Actually, no, we don't. We're not a methadone clinic, but I believe the gentleman at the table over there do.
Oh, okay, I'll go talk to him. I'll go talk to him then, thank you very much.
But we've got some other treatment if you'd like to hear about options. if you'd
No,
like.
I think that's the one that would work for me.
And that's the choice you'd like to make. Then I would refer you to those gentlemen over there for the choice that you're interested in. If you do not want to stop smoking marijuana today, then that's not where we're going to go. I'm going to go wherever it is that you want to do. You want to stop? You want to stop opiates? Do you want to try and do it without medication? Let's talk about that. You want to be interested in other options? Let's talk about that.
Thank you.
Sure. I hope we're all being trained on that.
So is it okay to want to choose to use a secondary drug when I go into treatment, even though I'm seeking treatment?
Now, I'm going to go in a different direction. That's an interesting question that you pose. A person comes into treatment with polydrug use, whatever drugs they choose to use. So they're willing to give up one while maintaining the other one. As a professional and a clinician, how do we deal with that? I'm okay with letting the opiates go, Oxycontins, the heroin, anything associated, anything other.
What do you mean letting it go?
I'm willing to just, okay, I want to discontinue the use of the opiates, not let it go. I'm willing to discontinue the use of the opiates and the heroin and anything opiate-based, while at the same time, I want to continue to smoke marijuana. So as a professional and as a clinician, and I heard him say referring this person out. Okay, well, okay, and I
Because I'm not a meth clinic.
right, right, I understand that.
Here,
Right.
I'm not gonna tell you and judge you that you cannot use your marijuana, right? But if I can get you to come back to talk to me next week, right? Maybe we can start to have some more
So you
discussions
said
about it.
refer him out for the treatment for the opiate problem, and then he come back to you for the marijuana.
If that's what he wants to do.
Okay,
But
right.
He doesn't see marijuana as a problem, right?
Correct.
Right, so why would I refer him for a problem he doesn't think he has?
And it leaves it open for dialogue, so that's
Okay,
itself.
but we're separating the drug, and addiction is an addiction. You know, if
Not
you
to
have,
him.
not to him.
It is to you, that's the point, he's kind of named.
See, this is, I'm trying to understand what we're talking about here.
So is your inclination to refuse me treatment unless
Of
I'm
course
willing
not.
to give it all up?
Absolutely not,
Okay.
because we have an open door policy.
Okay, so what's your inclination about this that seems
I'm trying to,
conflictual?
like, how do you deal with that? Okay, so I believe that's okay, if that's what if that's what the person comes in the door and tells you, then we have to do a treatment plan tailored around this man. You know, we have to treat him accordingly, you know, with the services that we have. If we cannot address the issues that he has, then of course I believe in referring this man out. I believe that. But if a person comes in, because I believe eventually we going in the way of clients doing their own treatment plans.
Oh, yes.
And that's where we're headed. They're gonna come in, and we're gonna do an assessment, and the clients will write their treatment plan, and we will sign off on it and adhere to it, because this is what the client is gonna be telling us as a clinician how to best treat me. So we might as well be
Yes.
prepared, we might as well be prepared for that right now.
Yes?
Right.
Can I just ask why you're not
Absolutely
doing
true.
that now?
Okay, one at a time, please.
Can I just ask why you're not doing that now? Why isn't your client writing their own treatment plan? If it's their goals, why wouldn't they be writing their own treatment plan? Right. Why would we write a treatment plan for anybody?
So the question is, why are we not now having the recovery write his plan for getting well? We do?
I mean, it's going on now, but I'm saying it's going to be general consensus. Maybe it's widely practiced now. I don't know.
I've always thought it was a collaboration.
I'm just saying, it's just information I'm just putting out there.
The clinician and patient. That's what I think.
I thought, I was on the assumption a treatment plan is a collaboration
Right.
between the patient and the clinician.
It is?
Right.
Now, that's,
But the question seems to be who's driving that?
Right, exactly.
Who's driving
Is it
that?
us or them? Who's driving it? Us or them? The information you're getting.
Okay, so I think that if this is no choice down here, some people start real low, and what we want to do is increase their ability to make healthy choices. Other people may start here, and we're still moving them up. Not everyone starts in the same place with their ability to make choices. So the relationship between who drives it is going to differ depending on the person and what the severity of the problem is. Okay? We need from the get-go to honor choice, however. From the get-go. I started this conversation about respect, which I called admiration, but respect. Okay? That's a key element of respect. Okay? If, people refuse medical treatment because of their religious points of view or other points of view, it's their right. Okay? But we hold on to this concept, and not to pick on you, but the thinking, addiction is addiction, you stupid, and if you don't fix it all together, you'll never get well. Well, that may be true for some people. We don't necessarily know it's true for everybody, and we don't know whether it's true for that individual. Okay? What are you thinking? How are you feeling? Is this a...
Well, it's always supposed to be individualized. Again, with, I don't know who practices it or who doesn't.
Right.
But treatment supposedly has always been individualized care. Now, whether they practice it or not, I don't know. But that's the concept, that treatment has supposed to be individualized.
Are you saying that being individualized implies choice?
Yeah, of course, yes. They got the right to make decisions. They have their right to say, I want this or I don't want that. Because when we take away a person's rights, then we're no longer giving them choices.
Okay, I think though, and just my perspective, that in the past when we've talked about individual treatment plan, it was based on the individuality of your needs. Of the client's needs, not the client's wants or strengths.
No, well, whatever, even based on their strengths as well, because one of the things that, for example, a person that came into treatment, hit rock bottom, they still have their job. So their strength was they were still able to maintain. And throughout my whole addiction, I kept 3 jobs.
Yeah.
So it's not always saying that individualized does not mean don't look at the strengths. Yes, individualized means looking at the strengths and building on that too.
Sure, absolutely.
Yeah, that has supposedly been the concept. Now, how individuals do it or different agencies do it, that's the question.
Sure. And how folks have interpreted that in the past, does individualization actually mean choice? Does it mean that the recovery gets to drive the plan? I'm not sure that we've vested individualized treatment with those concepts in the past. Okay. Yes.
Based on, you're talking about doing all this in 9 hours.
Yes!
So,
yes!
I mean, it ain't too much you can do in 9 hours.
Yes.
And so it depends on what modality of treatment you're dealing with.
Yep.
Inpatient,
Absolutely.
outpatient, intensive outpatient, or whatever.
Yes.
But you're only dealing with 9 hours.
Yep. There's a finite period of time that we have contact. What do we need to do? That's an important question. Okay. Sure. Oh, absolutely. Absolutely. You could stretch it a little.
Yes, you give therapeutic assignments because you know you can't cover everything like in 9 hours. You have limited time. So you bring in other resources and therapeutic activities for them to take home.
So one of the things we try to do are use techniques that lengthen the amount of contact time or connection with doing things for one's recovery. That's one of the things we can do. Okay? We also need to prioritize. And not everyone is starting from the same point of difficulty or deficit. We need to say, okay, what's your starting point of wellness? And I don't think traditionally we've asked those questions. Okay? Does that, I don't think we can do everything.
No, I mean, like he was saying about the marijuana, if it's outpatient and you treating, you got a opiate problem. Outpatient, you know, depends on what he come there for.
Yep.
And you may have to do one thing there and something in another place.
Sure.
But if it's inpatient, some people you can allow with certain doing certain types of drugs around a certain body of people.
Sure. And so if I'm going into outpatient treatment and I'm mandated because of a DWI, I'm probably in a different place than if I'm coming in there because my significant other is creating some difficulty for me because of my use. Okay, those are two different, and we need to recognize the different starting points towards the wellness piece. There was a hand here.
When I hear about this model, when I listen today about it, it goes back to the model of Second Genesis back in the 70s and the early 80s. You could drink.
Mm-hmm.
You could go out on pass and drink, and as long as you wasn't using a narcotic,
Yep.
you was able to stay in that program. So it goes back to that model again.
Yes, yes. It's also important to help folks clarify what does the use of that other thing mean. Okay, as folks clear up from the use of one drug, we can probably see the impact of the other more clearly.
A lot of times people go to the treatment and people categorize the chemical that they use. Like he might say, we're not going to treat opiate, but we'll do something else and allow you to smoke. I mean, it's not really too much difference in which one you choose to let them do.
With which, what you choose?
A chemical.
Oh, yes.
The chemical is a chemical.
Yep.
But sometimes we allow people to smoke cigarettes. And as if it's not a chemical, but you can't come in if you drink it.
The first 8 years of my recovery from alcoholism, I smoked cigarettes addictively. No one thought that I was not in recovery. Okay. We think differently now. We're beginning to think differently. Okay. But yes, we categorize them. Good drugs, bad drugs, safe drugs, not safe drugs. Sure. So being able to select this pathway and how I do it, okay? I'm choosing abstinence, but I'm not doing that AA thing. Okay? There are different ways to do it, okay? Depending on what I see as the behaviors and beliefs that will get me to the place where I want to go. Okay? That may not be an accurate vision that I have. Probably not. But it's the one I have about my wellness that I'm willing to work towards. So, recovery capital. We're going to break in. Do you want to break now? Because I can do that now, Simone.
I'm good.
Yeah? Okay. Why don't we take a break now? It's been a pretty intense conversation, then we'll come back and talk about recovery capital.